Okay. All right, somebody got admitted, so I don't know if that
Oh,
was
wow. Yeah.
you. Okay, yeah, all right. I was on the wrong one.
Okay. I'll sign, let me sign back in.
So,
Let's see, so it's still making me.
right, I got the, yeah.
Hi.
All right, sorry, everybody. I was on the, I had the wrong, I was on the wrong Zoom meeting, so my fault. So I hope we didn't lose too many. So tonight,
Register.
Joe, I'm going to make you co-host, okay?
Yeah, definitely.
Sure.
It's still telling me you have another meeting in progress.
No,
Okay, I think it's letting me in.
looks like it's letting you. Should have let you in.
Yes. Okay, got it.
Okay. Okay. I'm going to make you co-host. Okay, because tonight, our speaker is not going to be available at 6 o'clock. So we have a video that we're going to look at. It's her webinar on Ehlers Danlos syndrome. So again, first of all, sorry, I was on the wrong Zoom meeting, so I hope we didn't lose too many. So Carol McMakin is, she was on with us last year. I've spoken at her group a few times. Her group is the frequency specific microcurrent. It's a type of device it's kind of like a TENS unit electrical current, and they've matched different frequencies to different organs, different disease entities, and they have had some fairly good success with it. It's pretty interesting. I think I got the story right, that she had gotten married to an old osteopath, and this was in the 70s, and they bought a practice in somewhere in Kansas, I think, or Nebraska, and in the room was in the place they bought was a device that was an electrical stimulator, and it came with different types of frequencies, and they started playing around with it. They've been using it ever since, and she's got a pretty big following. She's got about 5,000 or 6,000 practitioners. She teaches all over the world this technique. I've been threatening to learn it myself, but I always have something else to do. And she was on last year with us. She's going to be on at 6 o'clock to answer questions, and she can explain it a little bit better. It's a little bit after 5. So what I have now is I have one of her webinars, and this is on Ehlers Danlos syndrome. I hope you all have at least a smattering of an understanding of what that is. If not, I think she's going to explain it. We're going to let Dr. Nario in first, and we're going to get rid of that. And we're going to, let's see, what else do we need to do? We need to start our recording. I think the recording started already. So let's find the video. Get rid of that, and here we go.
Okay, this is the Ehlers Danlos webinar, and this is what we're going to be talking about for the next 65 minutes. What are we treating? So we're going to go into more than you ever wanted to know about Ehlers Danlos and hypermobility spectrum disorders. I didn't even know there was a hypermobility spectrum until Tuesday. Details about the connective tissue configurations and the genetics. What are the tissues from an FSM perspective? How do we treat these syndromes? What are the risks of treating or not treating? And what can we expect? And how do you do this? That's the plan. So there's 13 subtypes of Ehlers-Danlos. Then there's the HSD, generalized, peripheral, localized, and then historical. So that's older people that were gymnasts or really hypermobile when younger, but they aren't now. So there's actually a way of scoring this. It's called the Baton score. And apparently there was something different, Carter and Wilkinson. So this is sort of a patient version of this. Can you put your hands flat on the floor with your knees straight? You score yourself. That's one. Bend your elbows backwards, bend your knee backwards, bend your thumb back. Can you bend your little finger at 90 degrees? So this one, number 5, and it's, I don't know, they say little finger, but I'm used to using the index finger, and it goes past 90 degrees in the patients I've seen. So 100 degrees, 105. It's pretty extraordinary. That's the index finger. So maybe the little finger is more difficult to bend. So when it gets to 90 degrees or 110, it's really a thing. So this is from the website, ehlersdanlos.com. EDS is a group of genetic connective tissues disorders resulting from collagen defects or the defects in proteins that interact with collagen. So it is a multi-system disorder, and as you'll see, there's going to be a lot of different symptom presentations from just bendy and hypermobile to lethal. No two patients are the same because the connective tissues that are affected in the system are different depending on the patients. So it was named less than 100 years ago. There are still large portions of patient reports that are unknown. 13 subtypes, I had no idea. Many people with EDS look healthy, making the disorder largely invisible. And this is from their website. It's on, there is no cure, but as you'll see at the end of this hour, there's a possibility that FSM changes this. So signs and symptoms: body pain, dislocations, subluxations, which is partly dislocated, hypomobility, arthritis, osteoporosis, and you'll see that arrives because of defects in the collagen that hold bone together. If you saw John Sharkey's lecture last year, he demonstrated that bone is calcium-filled fascia. Bone is fascia. So when you get difficulties with the collagen that forms the bone, you get osteoporosis, skin tearing, stretchy skin, really soft skin because it's missing the collagen at the bottom, mitral valve prolapse, easy bruising, fatigue, Chiari syndrome, sprains, GI issues, atrophic scarring, that's scarring without a lot of ridge of connective tissue in it, muscle spasms, poor healing. Look at this list: POTS, organ rupture, patient dies of an aneurysm. Did he just have Ehlers-Danlos, prolapse, irritable bowel, dysautonomia, flat feet, swan neck deformity, gastritis, joint pain, muscle pain, surgical complications because the thing won't heal? So collagen is everywhere, and the genetic changes that result in a diagnosis of Ehlers-Danlos by a geneticist is different for everybody. And where it shows up and which kind of connective tissue is in which tissue, we don't actually know because nobody studies this stuff because there's no drug that's going to cure it. So this is a slide you can just go back to, but it lists migraines, orthostatic intolerance, POTS, mitral valve prolapse. It's a lifelong condition that you were born with, but I've had emails from 2 different patients that say that there are infections like Bartonella and Mycoplasma that cause Ehlers-Danlos in later years. You're born with it, but it doesn't always show up in the milder forms. So I wonder if the infection basically affects the vagus, which causes inflammation, which makes the pain show up. So there's that. Classes. So this is the 13 types. Classical Ehlers-Danlos, skin hyperextensibility. So if your patient can do this with their skin, or this with the skin on the back of their hand, or that guy's sort of famous on the internet. Generalized joint hypermobility. So this is the Baton 9-port score again. It's autosomal dominant. So if mom and dad had it, the kid's going to have it. And these are all have to be confirmed with molecular testing. So 3 centimeters in the neck, elbow, or knees, 1.5 centimeters for dorsum of the hand, distal forearm, 1 centimeter for the palm of the hand, but I couldn't find a picture of that. So main symptoms of hypermobile EDS, tummy problems. So that's the digestion. We'll get to that at the end of this. Dislocation, stretchy skin, easy bruising. Why would you bruise easily? That's because the basement membrane in the arteries is made of connective tissue. So if that connective tissue in the arteries is defective, the artery is going to bleed more easily. Bendy joints, pain, and you'll see that I think that comes from the spinal cord, fatigue, feeling dizzy. Why would that happen? Because the ligaments and connective tissue and tendons at the upper neck are attached with connective tissue to the vertebra. Highest percentage of proprioceptors in the body are at the suboccipital muscles. So if those muscles and ligaments are at C1 are lax, C1 is going to move, and those muscles are more stretchy, and they still have the same amount of proprioceptors. So this condition doesn't affect the proprioceptors, it just affects the connective tissue. So that's why you feel dizzy. So they may look like they have a vestibular injury, but it's a cervicogenic vestibular injury because of the stretchiness at C1. So this little girl she's our target. Gastrointestinal issues, we'll see why. POTS, chronic pain, fatigue, easy bruising, hypermobile joints, TMJ, osteoarthritis, poor healing, prone to injuries. So if the patient's history includes these kind of things, I want you to start looking for Ehlers-Danlos because it now is something we can treat. And the problem with EDS, as you'll see in a few slides, is that they don't find it because nobody looks for it. Palpitations, lightheadedness, dizziness, fainting, elbow joints, right, joint pain, and you'll see where that comes from: hypermobility, mitral valve prolapse, orthostasis, and sinus tachycardia. Okay, and we'll see about that. Classical EDS, this one's different. It's autosomal recessive, not dominant, and it's TNXB gene. And this is the easy bruising. So this kind of EDS is more associated with bruising. And then there's the Baton score for hypermobility. Google Ehlers-Danlos and you'll find all sorts of cool stuff. That's where all this came from. Cardiac valvular EDS, apparently the connective tissue is specialized in the heart valves. So it's severe progressive cardiac valve problems, aortic and mitral especially, skin involvement, hypermobility in the joints. It's autosomal recessive, but you notice it's a different gene. That's the 1A2 gene, which is different than the one that's in classical. So these are genetic testings that are done by the geneticist that you send your patients to. Okay. Vascular EDS. It can be severe, can be life-threatening. There'll be a family history. And the gene associated with this is the COL3A1, which I don't know anything about. Arterial rupture at a young age, colon perforation, uterine rupture during third trimester in the absence of previous C-section or severe peripartum perineum tears. So this patient went through her life, at least until menstruation or teenage years, got pregnant, and nobody knew that she had Ehlers-Danlos until her uterus ruptured during the third trimester of pregnancy. Excuse me? I mean, this is really fascinating. And this is autosomal dominant. So somebody in the family should know that the person had it. Carotid cavernous sinus fistulas, those are up in the neck. Autosomal dominant, confirmed by molecular testing. This patient is going to need to see a geneticist. It is rare, very rare, potentially fatal. And the facial characteristics, look at that. You wouldn't guess that this kid had something wrong with him. Small chin, big eyes, long eyelashes. What's up with that? Narrow palate, midline flattening, deep set or almond-shaped eyes. I mean, who would know, right? Interesting, many sleep with their eyelids partly open. They have easy bruising, so very superficial veins and easy bruising. Vascular Ehlers-Danlos, so vessel rupture, aneurysms. So there's, see the aneurysm right there? So you test for it with, well, you send them to they get a vascular study with contrast and radiology, and you send them to a geneticist. At the end of this webinar, you're going to know more than most people about Ehlers-Danlos. Hypermobile EDS is fairly straightforward, mostly generalized joint hypermobility, and then feature A, feature B, feature C, and 2 or more of these have to be present in some combination. All these prerequisites must be met: absence of skin fragility, including autoimmune rheumatoid arthritis conditions that may also include joint hypermobility by means of loss of muscle tone and connective tissue laxity. So these prerequisites have to be met, and there has to be these other things that don't explain it. Okay. So this one doesn't have a specific gene associated. This one is obvious at birth: bilateral hip dislocation, severe joint hypermobility, skin hyperextensibility. It's rare. It's autosomal dominant. So these genes are starting to look familiar now, right? The COL gene, which is collagen, 1A1 or 1A2, and this is diagnosed obviously at birth and by a geneticist. Dermatospara, I can't even pronounce this one, Sparaxis EDS or DEDS, 9 major criteria, 11 minor criteria, 2, anyway, it's autosomal recessive. And I didn't include pictures, I think because the pictures were so creepy, I couldn't put them on, but it is a different mutation. And these people end up, so the craniofacial features, yeah, this one ends up at a geneticist too. This one becomes obvious by the time the child is, I don't know, looks like 2 or 3. Congenital lax muscles, congenital or early onset kyphoscoliosis, which suggests it's going to end up in a chiropractor's office. But look at this. Look at those pictures. Generalized joint hypermobility with dislocations, subluxations peripherally. So shoulders, hips, and knees in particular, it's autosomal recessive. So neither mom or dad has it, but the uncle they never met. And if dad was adopted, a brother that he didn't know about, or an uncle he never met. And these are different genes again, PLOD, which I don't know what it is. And for these people end up with a geneticist. So if you're a chiropractor and you see somebody that looks like this, don't even go there. Don't start adjusting the spine. Can you imagine what you do to an Ehlers-Danlos patient when you do a high velocity thrust? Same thing with the osteopaths and even the PTs. It's like, seriously? You start mobilizing these joints and they're going to dislocate. That's not a good thing in the spine. So there we go. Brittle cornea syndrome, this one, thin cornea. The other pictures on the internet were kind of too creepy to put on here. So I didn't. It's autosomal recessive, which means it's harder to find. Mom doesn't have it, dad doesn't have it, but his great uncle had it. So it's a recessive gene. Mom's grandmother had it, and it's recessive. And by the time you get down to the kid, nobody knows that it's in the family. So this is what they look like. And it is confirmed probably by an ophthalmologist when the kid has visual trouble, and then you send them to a geneticist. Short stature, progressive in childhood. This one is obvious at birth, and by the time the kid is 2 or 3. Muscle hypotonia, bowing of limbs, they're going to end up in physical therapists. Don't think they're good. If they look like this, they're going to end up in a chiropractor's office. But pediatricians in the group will see this. Autosomal recessive, these are the genes involved, and these people end up in a geneticist's office. And then you have to figure out how to manage them to make their lives more comfortable. That's what I'm saying. We can't fix these, they're genetic, but the potential exists that the FSM protocols can help these patients. Musculoskeletal, musculocontractural EDS. The pictures on these, it's really rare. So it was hard to find photographs of the patients. Multiple contractures, adduction, flexion contractures, or clubfoot. Craniofacial features that are evident at birth or in early infancy. And the pictures I saw on the internet were not particularly characteristic. You wouldn't look at that kid and say, wow, she looks weird. I think she has this rare kind of Ehlers-Danlos. But so characteristic cutaneous features, skin hyperextensibility, easy bruising, skin fragility with atrophic scars. And I'll show you what you saw what those were before. Increased palm or wrinkling. So there's the skin on the palms is more wrinkly because the connective tissue that should be strong on the palm of your hand and not have a lot of wrinkles when you do this, theirs doesn't do that. It sort of folds in on itself and they'll have wrinkles. It's recessive, which means these patients aren't going to know that it runs in the family. Myopathic, this one is really rare. Congenital muscle hypotonia, muscle atrophy that improves with age. So they're pretty messed up as children, but as the muscles develop and they have more growth hormone, the muscles develop, but they're still going to have proximal joint contractures. So see this one? 2 out of the 11 people known to have this kind. Okay. So hypermobility of distal joints. So her knees, hips, and elbows contract, but her fingers and toes and ankles are hypermobile. Autosomal dominant or autosomal recessive, which has got to be confusing for the average geneticist. And it has that collagen 12A1. So collagen is everywhere in your body. So there are a lot of genes that are responsible for it. This one, for the dentists in the group, severe and intractable periodontitis at early ages, childhood or adolescence. And the key for the periodontitis is the gingiva, the gums don't attach to the teeth. So see where the periodontal ligament is, how the tooth is constructed. See that? Okay. So that connective tissue that makes the tooth and holds the tooth to your gums isn't made right. There will be a family history of a first-degree relative who meets the clinical criteria, and it is autosomal dominant, so it's easier to find. So if mom had it, dad had it, Uncle Ralph has it, they know that when the kid's teeth starts coming in and the gums bleed, they know that it's genetic. And I mean, that's the good news. And the bad news is there's no way to treat it. So hypermobility spectrum disorders are similar to Ehlers-Danlos, but there's no gene identified because there's so many genes. Similar patterns, pathologies as the Ehlers-Danlos group, but there's no clear genetic markers, and the pathologies aren't as severe, but they involve similar symptoms. So you're still going to have digestive issues. You're still going to be diagnosed with fibromyalgia. You're still going to have joint pain, either because of the discs in the spinal cord or because your joints bend the wrong way or bend too much. Generalized HSD, hypermobility spectrum disorders, many hypermobile joints, peripheral, just the hands and feet, localized, hypermobile at a single joint or group of joints. And for our purposes, we're going to treat it as the same as for Ehlers-Danlos, same pathologies and mechanisms. They're just not as serious, but I suspect they're more common. These are more likely to be missed because it's not such an obvious life-threatening mess. Historical HSD, older people who are hypermobile when younger, but aren't now. So these are the people that come in to see you. Now, older has a very wide range, can be any place between 40 and 74, right? They come in for neck pain and low back pain. They were gymnasts in their teenage times. They were ballerinas up until the time they were 25 or 30, and a ballerina is considered old. And they're very hypermobile, which is helpful in their profession and their avocations, their hobbies. But when they're adults, older, they have facet syndrome, they have disc injuries, extremity joint involvement caused by the joint trauma when you're a ballerina or a 25-year-old gymnast. So we'll treat the joints, facets, discs, the vagus, autoimmune issues, inflammatory issues, and guts issues. These are going to remain after their joints are more degenerated, they're not as hypermobile. So the HSD disorders have all of these symptoms that go with them. And the patient walks in with POTS, I never think to check them for hypermobility. I can think of 3 patients right now that I missed, never thought of it. chronic pain, fibromyalgia, fatigue, easy bruising. I have a friend right now that moved to Australia. And we didn't find out she had Ehlers Danlos until about 2 years ago? Arthritis, look at that. Now, the joint hypermobility is the presence of too much movement at any given joint. What it is, part of a chronic condition and cause varying levels of physical disability. The hypermobility can occur with no other symptoms and be advantageous if you're a gymnast, so nobody cares. If you're a ballerina at the age of 7 and you can do the splits, nobody cares. You're a cheerleader in high school and you can do the splits, that's not a problem. Joint hypermobility is a part of a condition that causes pain and fatigue, like fibromyalgia. Part of a chronic condition, it can be accompanied by GI dysfunction. You'll see how that works out. Headaches, C1, C2 are hypomobile. Cardiovascular issues, dysautonomias, sleep disturbance, etc. What it isn't is you're not just flexible. It's not harmless because it's just pain. Joint hypermobile conditions are not always visible because the people avoid making the movement that makes them socially weird. Not something that everybody experiences. I can't do the splits. Never could, even when I was a kid. So it's not something that you can develop or that everyone experiences. And it's not always a cause for concern, especially if there are no other symptoms. So that's what it isn't. This is what it is. Okay. Now, Marfan's is interesting because it's a genetic disorder that affects connective tissue caused by a completely different mutation that tells the body how to make fibrillin. It increases a protein called TGF-beta, the increase in transforming growth factor beta, whatever that is, causes problems in connective tissue throughout the body, which in turn creates the features and medical problems associated with Marfan's. I'm just reading that slide to you because that's what I knew about Marfan's, except the fact that it's genetic, and you see patients that come in with hands that look like this who can do that. But Marfan is associated with mitral valve prolapse, aortic dissection, which doesn't usually turn out well, retinal detachment, fibrillin 1, arachnodactyly, which just means spider-like extremities, extra long arms, extra long fingers. They're nearsighted because of the connective tissue in their eyes, and they often have scoliosis, and it's genetic. So dad has Marfan's. It is recessive, it looks like. So mom doesn't have Marfan's. And out of the 4 kids, just do the Punnett square. Remember when they made you take genetics and you learned how to do these and they made you crazy? Okay, so 2, if they have 4 children or 1 child, there's a 50% chance that if dad had Marfan's, there's a 50% chance that child will have Marfan's. Does that make it dominant or recessive? I guess it makes it, I don't know. I'll let you guys figure that out. But it is difficult, but not always disabling. This was interesting. Michael Phelps, gold medal swimmer, built the muscles, protected the joints, and won, 5, 6, 7 Olympic medals. Basketball players, great actor. Vincent, I didn't even know his name, but everybody knows this guy. Howard Stern, Abraham Lincoln. And then you look up Marfan's on the internet, and that's the worst case scenario. So Ehlers-Danlos is female predominant, looks like after the age of 9. So in early childhood, you got about a 50-50 chance of getting it diagnosed. There's more males, right? So this is the incidence where it shows up, right? But look, some people are age 60 before it's diagnosed. That's nuts. And if you miss the diagnosis, don't feel bad. So I feel less bad after seeing this slide about the patients I missed 20 years ago. So latency of time between the first symptoms and the diagnosis in 636 patients. So age 45, 35 to, look at that. There are some people that aren't diagnosed until they're 50 or 60. That's interesting. Pain distribution, lots of pain in the lower legs, upper limb, spine, other joints. Now, this is interesting. And this goes along with if you're a psychiatrist or a GP or a psychologist, or if you're treating fibromyalgia patients. And the incidence of body pain makes them show up as fibromyalgia or neck injury or low back injury patients. But they have this psychological profile that is characteristic of Ehlers-Danlos. Anxiety, depression, eating disorders, and that relates to the vagus. We'll talk about that. Autonomic dysregulation, which is another word for POTS or POTS-like syndromes. Sensitivity to external stimuli. So everything jacks up their sensory cortex, and high emotional reactivity. So the event is this big and their reaction is that big. So you can download this paper at ehlersdanlos.com, or you can find it on PubMed, the American Journal of Medical Genetics, published in 2017. So this is the paper. And it is fascinating that I've had patients that come in and say, yes, I'm bipolar, I have anxiety and depression. And oh yeah, my blood pressure is kind of wonky. And they're on medication for the emotions, but they're 55 years old and nobody has diagnosed Ehlers-Danlos. That was interesting. So the neuroconnective tissue phenotype, right? How they show up. They have anxiety and joint laxity, okay? But that creates behavioral symptoms, psychopathology, as we would call it. So increased internalization, decreased proprioception, anticipatory anxiety. There's some part of your brain that knows that when you do this thing that everybody can do, it's going to hurt you. Your vagus is in charge of telling your brain this thing is going to create tissue fragments. And the hippocampus, remember the Vegas workshop? The hippocampus gets paid to remember things that hurt you. So the vagus, the hippocampus, the amygdala, that anxiety, phobias, somatic illnesses, dysautonomia, blue sclera, easy bruising, eczema, dyskinesia. It means you don't know where your body is in space. The kids that say, I'm just clumsy. Dislocations, prolapses, heterotrophic scars, or there's ones where the scar is indented. So normal scars, there's a raised lump on the top. Heterotrophic scars are where the skin, there's a ditch where the scar is. Defense mechanisms identified at the extreme of continuous axis, fight or flight, avoidance, and dependency. So those are behavioral. Somatosensory includes increased olfactory sensitivity. If your vagus is continually off, your midbrain is continually jacked up. The midbrain is connected, is sort of all information that goes from your frontal lobe to your sensory cortex passes through the amygdala and hippocampus. It's how you know that skunks are not nice and gas is not nice. You smell that, it goes through your amygdala and hippocampus before it gets to the sensory cortex. So there's an emotional learning and evaluation that happens in between the time you smell it and the time you get to where your sensory cortex knows what that smell is. It passes your hippocampus and amygdala evaluate the smell before it gets to your sensory cortex. Eye contact difficulty, once again, that's an avoidance thing. Selective photophobia, dyspnea, difficulty taking a deep breath, that's vagus. Dysphagia, trouble swallowing, choking, palpitations, joint pain, and enhanced sensitivity to weather and chemicals. There's an article in Townsend Letter we should have on the website fairly shortly. If it's not, is it already there? No, not there. I sent it to Kevin, but he's been really busy. And actually, I'm not sure if I sent it. But this enhanced sensitivity to weather and chemicals is related to this connection between the vagus, the amygdala, the hippocampus, and the sensory cortex and the cortex. Everything goes through the amygdala and the hippocampus, and all that information. So the weather, the vagus has stress receptors in the blood vessels that go to the back of your skull and in the dura. And so when the barometric pressure goes down, there's less pressure holding those blood vessels contracted. Does that make sense? Especially if the connective tissue basement membranes in the body of the blood vessel is not normal, not strong enough. And barometric pressure goes down, the blood vessel stretches because the basement membrane's not that strong. And the vagus goes, whoa, this is a problem. And the amygdala and the hippocampus go, I remember this. This always gives us, oops, headache. So when the barometric pressure changes, the vagus sends stretch receptor responses from the blood vessels and the dura to the hippocampus and the amygdala. And it all functions together. And that's why they're sensitive to weather and chemicals. Isn't that cool? So this is a great slide. Go back and check on that. So the biology is this. So the normal connective tissue looks like this. Ehlers Danlos looks like this. It's just not made right. This is how connective tissue is made. The amino acids are put together. They make tropocollagen. Those make fibrils, and the fibrils make fibers. So nanometers, 300 nanometers. Fibrils are 1 micrometer, and the fibers are 10 micrometers. So these are really tiny structures. You put them all together, and they make your TFL that holds your knee together. And it makes the ACL and the PCL and your shoulder labrum and the ligaments and all that. That's amazing. Structure function. So this is how those are put together. I don't know enough about it to even give a reasonable explanation, but this is what I found on the internet. So that's what I put on the slide. Some of you probably know more about this than I do. Now, the genes that go wrong, look at this. Collagen gene is up here. It goes to the ribosomes, puts together the pro-collagen chain. These genes can go wrong. That gene can go wrong. So this is the the mutation affects structure, synthesis, and stability in certain types of Ehlers-Danlos, EDS4, EDS6. If it doesn't hydroxylate or make the right disulfide bonds, EDS7, defective procollagen, collagen fibril self-assembly. So this is why there are so many genes involved in Ehlers-Danlos. Look how complicated it is. And any one of these genes can go haywire. And I guess in a less technologically advanced or less kind society, they would have died out. As it is, the recessive genes especially will reproduce and we keep the child alive, but it has certain disabilities that you saw in the other section where the problem happens. So osteogenesis imperfecta, scurvy, this is why, so this hydroxylation is done by vitamin C, right? Collagen fibers, anyway. So where the problems happen. Now, what does the vagus nerve have to do with Ehlers-Danlos? So the vagus nerve affects everything and keeps anxiety and depression at bay, opposes the sympathetic response to stress, conveys information from the organs to the brain. It's not just the organs. 80% of the information that goes from your body to the brain goes by way of the vagus. The vagus workshop is going to be even bigger this year than it was last year. Controls the throat muscles to send food and air down the right tubes. Insulin secretion and glucose in the liver. Suppresses inflammation by the cholinergic anti-inflammatory pathway. Fainting when overstimulated, leading to temporary loss of consciousness and bladder control. Controls digestion, is responsible for feeling full, increases gastric juices, gut motility, stomach acid, and actually determines there are sensory receptors in the small intestine that determine what nutrients you're getting, tells the brain, hey, you should really start craving pickles. Excuse me? Well, it's because you need something in the acid or the contents of the pickles. And that comes out of the vagus sensory receptors in the small intestine. Lowers blood pressure. In the case of illness, emotional state, decreases heart rate, vascular tone. It controls every muscle involved in speech. So patients with vocal cord dysphonia, spasmodic dysphonia, gag reflex, swallowing, coughing. So this is all in the vagus reflex. So this slide just didn't have the precision, but look at this. Ehlers-Danlos, upper cervical instability, cervicogenic nucleus, trigeminal neuralgia, right? Look at these arrows. You can, I don't know, maybe make the picture smaller or look it up. Vagus nerve, anxiety, autoimmune. So these are all interconnected. Vertigo, eustachian tube, Meniere's, right? Cervical sympathetic, cervical spinal cord, vestibular insufficiency, decrease. Look at this. It's just saying. So these are common clinical observations in patients with Ehlers-Danlos. And then look at the vagus nerve in our EDS patient. What controls gastrointestinal issues? The vagus. POTS has to do with the vagus, right? Orthostatic tachycardia, the vagus. Hypotension, the vagus. Cardiogenic syncope, the vagus. No significant arthritic arrhythmias means it's not the cardiac nodules that are a problem, right? All of this is the vagus. So how does it work? The vagal afferents notify the brain limbic centers of infection and trauma, pathogen-associated molecular patterns, damage-associated molecular patterns, tissue fragments. The midbrain limbic centers, so in our world, 89, upregulate, they get jacked up. They suppress the vagus, and during stress, injury, infection, and threat, the vagus is suppressed because it gets in the way of survival. Tissue injury is constant with EDS. There are constant damage-associated molecular patterns that are associated with Ehlers-Danlos. Now, this makes me wonder about the acquired Ehlers-Danlos that comes with infection. Does that have to do with the PAMPs? So that's the pathway. So how does the vagus work to regulate the immune system? Well, sacral nerves go to the colon. The vagus nerve goes to the spleen and regulates T cells and macrophages, celiac ganglion, those go to the colon, and all of this feeds back into the immune system. It is the vagus is an immune regulatory. So how does Ehlers-Danlos affect the vagus? Well, the DAMPs that come from the tissue injuries suppress the vagus. But my theory, look at the branches. The vagus is everywhere. Because of its connections in the blood vessels, there's no place in your body that doesn't communicate with the vagus, because everything's attached to everything. But I think, in addition to the DAMPs, the vagus is attached to everything in your small intestine. Look at that. And every time and the stomach. So every time this patient stands up, the 20 pounds of liquid and food and stool that's in the digestive system pulls on the intestines, and that pulls on the vagus. So it's connected physically, structurally to the vagus. Every time the patient stands up, the connections cause traction injury to the vagus and impair vagal function. Go back to the psychological aspects: anxiety, depression, eating disorders, autonomic dysregulation, sensitivity to external stimuli, high emotional reactivity, all are associated with limbic system activation. And that's associated with the vagus, and that's associated with the midbrain. You see where I'm headed with this, right? All right, so how do we treat it? FSM treatment. So the first thing I did on the first Ehlers-Danlos patient I saw was I treated 124 and 77 on her for an hour, alternating, I think. And I did it actually on her. Her major symptoms that she told me about were just the fact that she couldn't hold a water bottle. She could not do that. So she couldn't do that. Her hand muscles wouldn't work. So I ran it from neck to hands, and in 60 minutes, she could pick up a water bottle. That was kind of cool. Then she came to a seminar 2-3 months later, and I looked at her pain diagram. So I ran 124 and 77 with contacts at her neck and feet, and that worked. I think it was between an hour and 2 hours. It was at the end of the day at a seminar. If you were in Denver a couple of years ago, I think it was 2018. So this particular 124 and 77 reduced hypermobility in every hypermobile and EDS patient that I've treated. And there's probably 10 in the last 2 years. Finger range of motion returns to normal. That was kind of interesting. They're used to bending to 110 with the index finger, and all of a sudden it stops at 80. That was weird. Elbows and knees were not as responsive. So at the end of 60 or 90 minutes, elbows and knees were still hyperbendy. Skin laxity was reduced. That was kind of interesting. And that brings me to, I keep saying we can't put tissue back that's not there. What are we doing when we run 124 and 77? I have no idea. None. Anybody gives me a Diana Cross, if you're listening, if you can come up with a model for how it is that 124 and 77 works, I'm with you. That'll be fun. And the effects last about a week. And male patients typically don't retreat themselves. Yeah, right. I've lived this. I'm 28 years old, 30 years old. I'm not going to treat myself. Female patients tend to treat themselves. So that was interesting. So 124 is what you treat with the connective tissue, but that doesn't change the pain diagram. When I saw the pain diagram in the Ehlers Danlos patient, it looked like a cervical trauma fibro patient. Circles at shoulders, elbows, hands, knees. The outside world, the Ehlers Danlos world, thinks that this comes from the joints. It went away with 40 and 10. The body pain that she had went away with 40 and 10. So think about this. Pain diagrams are the same. Well, what's the disc annulus made of? Connective tissue. If the connective tissue doesn't work right, what's going to happen to the disc annulus? It's going to have little cracks in it. It's going to leak, right? The nucleus material can then affect the spinal cord just same way that cervical trauma fibro does. So people assume the pain is from the joints, but in our world, it's 40 and 10. You look at that pain diagram, and if I did my job right, you're all thinking about fibromyalgia. So you'll treat these people for 40 and 10 to get rid of the pain, but you may or may not think of treating the connective tissue. So from now on, every time you see a fibromyalgia patient, ask them to bend their fingers. Can they touch their wrist with their thumb? I don't do the other parts of the Baden scale, but those are easy. You can do those with them sitting in a chair. Then 100% of the time you treat the vagus. How do we treat the vagus? Well, quiet the activity of the medulla where the vagus comes from and the midbrain, which turns the vagus off, and then treat the vagus for trauma. If it's getting traction injuries, it's definitely traumatized, increased secretions and vitality in the vagus. And the ability to treat the vagus in 60 minutes makes FSM unique. It helps reduce the psychological issues temporarily. It improves digestion. They get up off the table. They don't have POTS anymore. Reduces inflammation, which can be responsible for the joint pain. And you put the contacts at the neck and abdomen because technically the vagus stops at the abdomen, but I guess you could run it neck to feet. Once again, this goes 60 minutes. Now in the Vegas workshop, all of these run for 4 minutes. The other night, I treated an Ehlers Danlos patient for 90 minutes, and 30 minutes of that, I ran increased secretions in the vagus because it made her so stoned she couldn't talk. And I just, anytime I went off of it, she got unstoned. So I stayed on it. Her heart rate stayed the same, didn't change. So I'm just saying. Then the concussion in vagus you have. Concussion in vagus is a perfect combination. Contacts at neck and abdomen. So remember 6.8 changes genetic factors? Does it really? Maybe. So the basic concussion protocol, 6.8 and 38, but then you still need to do 40 and 94, 40 and 89. Now the question is 40 and 92, because these people are hypersensory aware. Not sure if this would help. Why would you want to quiet down the sensory cortex? Because this midbrain, the amygdala and the hippocampus have been screaming at it for 27 years. And so their sensory cortex is hyper aware because the amygdala and hippocampus are sensing threat no matter what the patient does. And then trauma in the vagus, increased secretions. This says 4 minutes each. I've had one experience where I ran 81 and 109 for 30 minutes. Patient just kept feeling better. It was interesting. Now, after you get rid of the tendinopathies, so you may have to treat 124 and 191, as well as 124 and 77. These are Kim Pittis's slides. So from module 2, module 1, the pain and injury, right? So 40 and 396, reduce the nerve pain, then treat. If these tissues have been chronically injured, are you going to have adhesions between the nerve and the fascia? So even if you get rid of the Ehlers Danlos on the first day, 3 days later, you're going to have to treat scarring between the nerve and the fascia, because you're not going to do that the first session. Release the adhesions, move the nerve and fascia. Remember that you move it really slowly. And then what do you need to do? The cerebellum has no idea where this arm is in space, right? Because in 60 minutes, you just changed everything. So increase secretions, reconnect it to the brain, increase secretions in the nerve, the spinal cord, follow the spark, 84, the cerebellum. And this one is where I'd spend most of your time, because we're not sure if you want to increase secretions in the sensory cortex or decrease them. That one I haven't played with. But I'd increase secretions in the cerebellum with the contacts of the spine and the nerve end. You can do this from neck to feet. You can do it from neck to hand. We had pictures for neck to hand, but you could run this neck to feet and have the patient stand up and just do a side to side weight shift, and then move their hands, and then move the affected muscles. So you could see this patient 3 times in the first week, run connect 124 and 77 for a while, and then do this part like on the second or third visit in that week. And then, so you see how you kind of put it together into a treatment plan. And then the digestive issues, you're going to have to treat small intestine or SIBO. And so trauma and vitality in the parasympathetics, you got to be careful if it's the diarrhea kind of SIBO. Treat the infection. Why would there be infection? Well, because it's SIBO and they have dysbiosis and bloating every time they eat. That's their definition of digestive problems. But in our world, what is it? Well, the vagus regulates the pancreas, digestive enzymes, the small bowel, and the colon. So you can, this is an hour's worth of treatment, even on a custom care. So you can take SIBO, add the vagus to it. So you treat the parasympathetics and include the vagus, and then I would treat just I generally with SIBO, I just treat the small intestine. But if enzyme secretions are a problem, you notice we're not dealing with the islets, we're dealing with the pancreas and digestive enzymes. So that's a thought. So remember this from the core, disc and facet pain patterns are pretty much identical. You kind of can't, now the sides are reversed, but can't tell the difference. Facet pain is worse with extension. Disc pain is worse with flexion. Because these patients are hypomobile at every joint, they're going to be worse with flexion and extension. So you're going to treat facets and discs. How do you do that? I would do subacute facets and subacute discs. I'd modify it to take out 91, right? It's not a one visit fix. This is going to be the part of their pain that gets bad every time. You have to strengthen and stabilize spinal muscles. Patient will need to treat themselves regularly at home. These people will end up with custom cares, and then see a good physical therapist that knows how to stabilize the spine. And that's just the setup for neck and low back. Extremity joints, create a protocol. I don't have an EDS protocol in custom care. And I got to tell you, I'm not going to make one. You can do this. Modified, I would copy, clone, extremity joint MLTB subacute. It's not acute, it's not chronic. You don't want to do chronic. And just modify it, shorten it. What is the problem? What gets torn and broken? The connective tissue, right? The ligaments, yep. The joint capsule, 480. 214 is the meniscus. If you haven't been to the advanced, this is new for you. And 191 is the tendon. So you get the flat tendons, the round tendons, and pretty much everything made of connective tissue in the joint. Then when the joint bashes around, what gets damaged? Inflammation. What's in the joint? What tissue is it? Cartilage gets beat up. Periosteum, because the connective tissue and the tendons and the ligaments attached to the periosteum, so it gets inflamed. It might even get torn and broken. 191 is the tendon, 195 is the bursa, 100 is the ligaments, connective tissue, 59, 39. 49, then vitality in all those parts. So you could create an EDS joint protocol, an EDS facet and disc protocol. That's pretty much you can do whatever you want. It's not like we know what we're doing with this one. So far I've seen 10 patients in the last 2 years. The results are normalized range of motion, like in 60 minutes. My brain, I don't understand it. Reduced body and pain, it's 40 and 10, that's easy. Reduced anxiety and depression. Their mood changes when they get off the table and it doesn't hurt. They don't know what to do with it. Not sure why. It's either the vagus or just, we've treated the vagus or affected the vagus, or is it just that you're less anxious and depressed when your body pain is in a 7? And they improve digestion. Results last about 1 week. No patient has been followed long-term and there's no negative outcomes or side effects. The thing I forgot, I just remembered what I forgot to put in. Where is it? It's up in the spine. This is the place where I guess I need to put it. In one of the Ehlers Danlos patients I treated, 124 and 77 did great every place else. But in his neck, it was 124 and 443, the dura. So the dura is made of connective tissue, pretty dense connective tissue. So it's torn and broken in the dura. That's a thing. All right. So what don't we know? Well, there's so many things we don't know because I only have 10 patients. Once you get to 50 or 100 patients in case reports, either stuff I do or stuff you do, can we help with the vascular effects? Connective tissue, treat the arteries, treat the capillaries, right? Trauma, torn and broken, inflammation, vitality. Can you change the genetics? Remember 528, the solfeggio frequency to repair DNA in the connective tissue, maybe? 6.8 and 38. We don't know who it's not going to work on. The more severe forms, obviously, we don't see them much. The hypermobility syndromes we see all the time, just miss it. You're not going to miss it now. Can you modify the treatments so they last longer? We don't know that. Patients need a custom care. So what do we need as a group? Everybody that's on this. More cases, obviously. I need you guys to start recognizing it and treating it. More experience with what works and what doesn't work. How do we know? So we and our patients can have realistic expectations. You can't say to somebody, piece of cake. I mean, I kind of do that, but I really don't know with 10 cases. When you get to 100, then you kind of know. I need more long-term data. I need any data. I love treating, but I'm terrible at collecting data. I don't do the range of motion. I don't do the Baden score, and I should. But the first 10 cases, you don't expect to be able to treat it, so you don't really check, right? Simple hypermobility is fairly common in musculoskeletal patients, but EDS is rare in the general population. And the good news for us is nothing else works very well in these patients. So we have really a chance to, as a group, to make a huge difference in these patients' lives. So the symbol of the Ehlers-Danlos website is, you know, when you hear hoofbeats, look for horses, not zebras. Well, the EDS patients are zebras. They come with a constellation of symptoms that nobody recognizes. So that's what we know, what we need to do, what you can do. Go back and read this over again. The advance this year is live stream only, which is good news and bad news. I'm going to miss seeing you guys, and I'm going to miss the great food at the hotel in Phoenix. But we're going to do a 5-day live stream, which means I'm going to be recording a 5-day. We're not going to use an old one because, as you'll hear from Kevin, I was changing slides at 2:00 this afternoon. So the core will probably be slightly different. David Musnick can't help himself. He puts in new slides. The FSM Sports was supposed to be in Phoenix, but Kim Pittis is holding it January 9th and 10th. You can find the directions for how to sign up. February 25 and 26 is the advanced. So my problem has been multitasking.
There we go.
I don't know. It's a little arrow.
There we go.
There we go. Okay. Copy the slides, yes. Oh, mass cell activation, MCAS, that's gonna, Jeff, that's going to be in the 5-day core or the neurovisceral core module. David Musnick does a great job with MCAS. It is always associated with the vagus. The reason for the MCAS is not part of the dysautonomia. It's because the vagus has as its job to suppress or regulate, control the immune system. Go back and look at the Vegas workshop from the 2020.
Are we there? Can you hear me?
Yeah, we're here, Carol.
Hi there.
So everybody, this is Carol McMakin. She was our speaker for the evening, and I guess the rest of that webinar was announcements and bric-a-brac.
Yeah. For
Decided to cut it off there. A lot of questions. First of all, what is FSM?
yes,
That because a lot of our people are not familiar with it.
right.
And what you know, you always tell the story, so go ahead and we'll take it from there.
Okay. Well, a lot of those numbers that you saw are frequencies from that I got from an osteopath who bought a practice in 1946 that came with a machine that was built in 1922. So in the US, from about 1905 through 1925, there were people, MDs and osteopaths used frequencies to treat patients. An electromedical digest recorded the data. They had journals, they had research clubs, they shared frequencies. And when the Flexner report came out, by 1927 or 28, the use of frequencies, homeopathy, herbs, nutrition was all illegal. So drugs and surgery was the only thing that was left. And the machines either went on the junk heap or went in the back room. And Harry Van Gelder was an osteopath who bought this practice in 46, walked in the back room, lifted up the sheet, and there was this machine and a list of frequencies, and he taught himself how to use it. George Douglas went and worked with Van Gelder in 1983. He and I got together in 91, and we started using the frequencies on a microcurrent machine in 1995 in my practice in Portland. I'm a chiropractor. I do physical medicine. And we started out treating muscle pain, then went to nerve pain. Then I lectured at the National Institutes of Health on one frequency combination that treats the full body pain associated with fibromyalgia. 40 hertz on channel A is the frequency to reduce inflammation. 10 hertz on channel B is the frequency to address the spinal cord. I treated 54 patients with 54 patients with fibromyalgia from spine trauma, and 58% of them, almost 60% of them, recovered from fibromyalgia in 4 months, but 100% of them had their pain go from an average of a 7.4 to 1.4 in 60 minutes. So I took these cases to NIH in 2000 and gave a grand rounds presentation at the invitation of Jay Shah. And I said, okay, I've done this at that point 27 times. There are no failures. There are no side effects. Somebody needs to tell me how to measure what it is that's happening, or nobody's going to believe it. So Terry Phillips came up and he said, you send me a spot of blood on blotter paper and I will tell you what's changing. I treated a patient, sent him the blotter paper, and 6 weeks later, 5 weeks later, he sent me back data that says that 40 hertz on A and 10 hertz on B reduces all of the inflammatory cytokines, interleukin 1, 6, 8, TNF alpha, CGRP, and substance P at logarithmic rates by factors of 10 and 20 times. That's not possible. Then substance P is produced in the spinal cord. And that's when we found out that substance P went down from 88 to 8. It went down by 10 times. And that's when we knew that 10 hertz actually addressed the spinal cord. So those numbers that you saw, that webinar was recorded for my practitioners when I first started with Ehlers Danlos. At this point, we haven't had any failures, and it's in wide use across the country. They go from, and I do keep data now, they go from a Baton 9 to a Baton 8 or 1. So some of the Ehlers Danlos patients, and I know there's one person in the group that is an Ehlers Danlos patient. The last of the Baton score, the 9, is they can bend forward and put their hands flat on the floor. And when you shorten the connective tissue, certain proportion of Ehlers Danlos patients have tethered cord. So they can still, once you tighten the connective tissue, the tethered cord gets worse. Then we treat the tethered cord, and then they can't touch the floor. I have one patient, she just left. I'm still in my office at 6 o'clock on the West Coast. She just left. I treated her 3 times 6 months ago, and she is still a Baton 0 out of 9. She can't touch the floor. Her little finger stops at 70 degrees. It's permanent on her. So the frequencies, we did animal research in Sydney, Australia, and found that the frequency to reduce inflammation in the spinal cord, reduce inflammation in the immune system, reduced lipoxygenase mediated inflammation by 62% in 4 minutes. And I sent Dr. Clearfield the slides for the FSM introduction, and perhaps he can send them out to people that are listening.
Yeah, we'll put it on our website. And
Yeah, put
everybody.
them on the website because the data is just ridiculous. So locks inflammation by 62% in 4 minutes. And that was with everybody blinded. COX-mediated inflammation went down by 30%, which doesn't sound that great, but it's equivalent to injectable Toradol when Toradol was tested in the same animal model by the same researcher. And injectable Toradol is about as good as it gets. We have published papers on head and neck pain, myofascial pain, low back pain, another large collected control trial from India on low back pain, torticollis, nerve pain, scarring in nerves. I think there's about 15 peer-reviewed published papers at this point. The book that tells you how FSM was developed is called The Resonance Effect. And that is, it's an audio book, and it's at Amazon. It's a quick read. It's the story of how I developed it. There's an FSM textbook that was published by Elsevier, and that's a little bit outdated, but it's with Ehlers-Danlos, it's amazing the number of people that have it and don't know. So everybody now that comes in, I treat chronic pain patients in this clinic, and everybody that comes in that had an auto accident 15 years ago or 12 years ago, and they still have neck pain, I do a bait and score on every new patient just about. So, because it's easy, right?
Carol, are you allowed to talk about your most famous football player? Is that? Or is
Oh
that...
yeah. Well, he mentioned me, so that was fine. When he was, I treated Terrell Owens after he broke his ankle. He had a high ankle sprain, which means that the interosseous membrane between the tibia and the fibula was shredded. He avulsed the deltoid ligament. He had an open spiral fracture in the fibula, and I treated him. I flew out, treated him as soon as he got out of surgery. They started treating the fracture right after he was injured on Sunday. I treated him Tuesday, and they said he wanted to play in the Super Bowl 6 weeks after this injury. And the surgeon was running around saying that it was a career-ending injury to anybody with a microphone. And we had him, the spiral fracture was healed. The ligaments were stable in 4 weeks. And when he got to Jacksonville for the Super Bowl, he couldn't run on Tuesday because everything cramped up. I arrived on Wednesday, and we spent 5 hours Wednesday night taking apart the scar tissues. So the frequencies to dissolve scar tissue are extraordinarily effective. FSM is basically applied biophysics. So our model for how it is the frequencies work is that the frequencies appear to change cell signaling and change what happens inside the cell to change how the cell has an output. And with scar tissue, the physics of it is that scar tissue is like a rubber band that's wound on itself. And the frequencies appear to resonate with the bonds that hold the scar tissue in a shortened configuration, sort of liquefies them. And when the bonds break, they don't connect back together. So we treated him for 5 hours on Wednesday, 2 hours on Thursday. He played in the Super Bowl like he'd never been hurt. And when he went into the Hall of Fame this year, he named me and Chelsea and Brian and Buddy Prim, his trainer, as the dream team. And then Maura has a question: combination therapies you find helpful to use with it. You have to have a stable state is what you'd call it. So with, let's say, Ehlers-Danlos, since that's today's topic, use FSM, the patient still has SIBO or irritable bowel. They have to make connective tissue, so they have to be taking vitamin C. They have to be on a hypoallergenic diet, at least until we get the vagus nerve working and the food sensitivities to quiet down. Almost anything we treat. So for example, if I'm treating a nerve pain or disc bulge, you have to take essential fatty acids to get the inflammation down, right? So you use FSM and you have the patient do certain exercises to stabilize the spine around the disc, bring circulation to repair the disc, treat the nerve. Nerve pain is easy. I have a young man who left here today. Last August, he was hit by a car while on his bicycle. He fractured his femur. They put a rod down the femur without putting a screen to keep the fat emboli down. So he was in a coma for 8.5 days with an embolic stroke. Some of the fat emboli are around the thalamus. So he has thalamic pain syndrome. On all the drugs that they could give him, his pain level was between a 7 and a 9. 60 minutes on the frequency to quiet the activity of the thalamus, and he's out of pain. So he left here last week with what we call a custom care. It's a small unit. And he came in today with his pain about a 6 because he's moving. And then I just put him on the unit, and he can go to bed at night and have his pain at a 0 when he wakes up. That's extraordinary. It's impossible. So the website, so I love osteopaths, and I love having people that are good at and interested in a combination of physical medicine and integrative medicine or functional medicine. Take our course, because you guys know what to do with it. So when you can treat nerve pain, that's easy. When fibromyalgia becomes the easiest thing you treat, when Ehlers-Danlos is at this point hundreds of cases into it by report, nobody's published anything. It's a slam dunk. I haven't had any failures. And we found out that probably 20% of every class that I've taught in the last year is Ehlers-Danlos patients. There's hypermobile patients everywhere. So go to frequencyspecific.com and find out how to take a course. You can take it on video, which I recommend because it's 5 days long, because I don't know what to send you home without. The visceral section is the last part. Physical medicine is the first 4.5 days. And then everything from asthma to irritable bowel to brain injuries to concussion to vagal tone to kidney stone pain. There's one frequency combination. The only thing it's good for is kidney stone pain. Takes the pain away. Dissolving the stone is a different project. So is there anything else?
Well, there's some questions in the chat. And then if folks want to hang around, so my new practice partner, Jen Boscovich, is on the webinar tonight. And as luck would have it, she's our Ehlers-Danlos patient. So,
oh, for heaven's sakes,
I'd like to hear a little bit from right from the horse's mouth, sort of. She agreed to talk and answer some questions. So But there's a couple of questions here. Now, some of it is about Ehlers-Danlos syndrome. I don't, not specifically about what you do. So like, is Ehlers-Danlos patients more prone to mold, for instance? That's a question.
Well, it's the challenge is that the vagus nerve is turned off by Ehlers-Danlos because it's turned off or down by infection, stress, and trauma. And when you have fragments of connective tissue floating around, the vagus nerve is downregulated, which I don't know that it makes you more susceptible to mold, but it's a contributing factor. Somebody said, Maura, where can we find practitioners? If you go to frequencyspecific.com, there's a tab that says find a practitioner. And I'm so excited because our new looking website is being launched on June 14th. So that's pretty exciting. But there are FSM practitioners, 5,000 practitioners in 23 countries at this point. So there's about 2,500 in the US. And you just Google them. We charge to be on the list, so not everybody chooses to be listed, but it's $89 a year. And what I'm hoping is that you and your team will take an FSM course on video. The equipment is inexpensive. It's produced in the US. It has 510K. It's ISO certified, and it has a CE mark.
You know, I'm getting closer. I've threatened for 2 years now. So
It's about time, Bill.
I know.
Yeah.
So I've actually spoken at the last two advanced courses for FSM. Carol's been gracious to invite me, and I've been speaking about traumatic brain injuries. And I even did a little homework and looked up the frequencies
Yeah.
on the
Well
last
done.
one. So
Well, and we have you come and speak because we treat brain injuries and strokes and the endocrinology and the nutrition that it takes to repair the brain is beyond my scope. And it's the missing piece is the endocrinology of it. So we've really enjoyed having you there, and your lectures are really, really popular.
we try to have fun, and your group is really terrific to be with too. They're really a fun group. So
yeah.
So Dr. William, can I just have 2 minutes just to interject here, because your speaker is very interesting. I'm Dr. Halasa and I enjoy everything you present. What I think it's missing is also the redox medicine, because once you understand redox medicine, makes sense everything that you say. And I think Ehlers-Danlos syndrome, there is mutation in the genes that makes the collagen corrupted, not perfect. And then you end up with this hyper elasticity. And there's two ways to manage it. There's a way that you can override the mutated genes. And that is a big topic that we're going to talk about it through a drug is called Amlexonax. But also there is an anti-inflammatory part of it and oxidative stress, which you are taking care of it by your microcurrent electrotherapy. And I can see that those electrons, they are going to reduce those free radicals, and they will dump the oxidative stress and the redox potential. And once you dump the redox potential in the macrophages, you would definitely decrease all the cytokines profile, because what activates the macrophage?
Wait,
Right.
stop, wait. It's not just the current. If you don't use the right frequency, it doesn't work. So when we treat the Ehlers-Danlos, there is one specific frequency combination that normalizes range of motion. And there is one specific frequency combination only, 40 hertz on A and 10 hertz on channel B, that gets rid of the body pain by reducing inflammation in the spinal cord. So the electrons do theoretically increase ATP production, but it's not just, it is absolutely not a current effect. The frequency has to be correct for what the patient has. So I understand what you're saying about redox potential and current, but it is a very frequency specific effect that is supported by data. So
I'm not stating that the frequency, it's part of delivering the electrons in the way that it will reduce the redox potential. You need to have that voltage, and you need to have that delivery in the right amount. Otherwise, it's going to be, it's actually may turn and become oxidative. But that's not, you know, the frequency. I'm not negating the frequency. I think frequency is part of it. But what I'm saying is that those electrons are neutralizing those free radicals, and part of it decreases inflammation directly. And the other part, what's the same mechanism of grounding, same mechanism of electrotherapy,
You can
phototherapy.
ground anybody you want, and you're not going to get them from a Baton 9 to a Baton 0 in 60 minutes.
Right. The frequency of add more value to deliver those electrons in a more efficient way. I understand that. I'm not negating that.
Okay.
The other
Okay.
part is that you said
Right.
putting the microcurrent in the neck, part of it is stimulating the vagus nerve, which actually has anti-inflammatory arm of the autonomic nervous system. So that's part of that.
Carol, so,
Yeah,
so is EDS an autoimmune disease?
no, it's a genetic condition where the connective tissue is made incorrectly. And that's one of the reasons I don't understand how it is that I've treated this patient 3 times and she no longer has it. I don't understand how it is we can treat them once and it lasts for 7 days or
Mhm.
2 weeks. How do you reverse? And it's very specific frequencies.
Mhm.
How do those 2 frequencies reverse a genetic condition and change the cell signaling that creates connective tissue?
Um,
So
somebody smarter than me, that like this person over here, this is Jen. She's our new practice partner, actually.
Hi, Jen.
And she unfortunately has Ehlers-Danlos syndrome. So,
It's
which I don't think I'd ever heard of before till she mentioned it. I had to go look it up.
it's I can't even tell you if
So,
yeah,
I was
it's
gonna let
easy to
her
treat.
like talk a little bit about some of her experiences.
Sure.
I know we had a hip out of place about 2 weeks ago, and she just turned a certain way, and boom.
Yep, just dislocates. The joint capsules are loose.
And Joel put it back in place, by the way. So
Yeah.
Thank you, Carol, for just bringing so much awareness to this. This is, for someone like me, I've been in the medical profession my entire life, didn't recognize it in my own family, and it took me way too many doctors and surgeries to realize, to be diagnosed. And I was still lucky enough to be diagnosed in my early 30s. But, what was fascinating was the diagnosis made me feel not crazy. Because no one can find answers, but we know that, looking back at my life, I guess it's like, wow, I was never really sick. It's always been Ehlers-Danlos. Everything I've ever had or problems. I even had exploratory research on my stomach as a kid. There were so many just strange things. Joints that would slide in and out of place was normal. Poor bladder control, even for my whole life has been, normal. Headaches, all of that. The chronic pain didn't start until trauma, like a car accident.
Right.
That was still as a kid, so I've had it most of my life. I would love to try therapies and be trained. This is amazing. I can share one. There was, one time in my life that I did become completely pain-free, and I do want to share that part. I don't know if that would help or not, but I was having so many digestive issues. It was getting so severe. I really didn't want to eat. I just didn't want to eat anymore. And I went to a detox spa and went about, it was like 8 or 9 days where we didn't eat food at all, just drank teas, did a lot of detox, colonics, really focused on alkalizing the body. They did not do IV therapies at that time, and a lot of focus on lymphatics. And I left, and I think I had 2 weeks, and I was like, wow, this is what normal people feel like. I had no clue people could feel like that. I was blown away. So I know that there's some detox component, and the more I can detox, the better I'll feel.
Yeah.
And yeah.
Well,
So-
and the other thing about the full body pain, everybody
Mhm.
thinks the joints hurt because the ligaments are lax. And in point of fact, the pain diagram for Ehlers-Danlos is the same as for fibromyalgia from spine trauma. And in our world, you look at the disc annulus and it's made of connective tissue. And in Ehlers-Danlos, the connective tissue is not made correctly. So the disc annulus is leaky. And the disc nucleus is the biologic equivalent of battery acid. So it activates, thins actually the anterolateral pain pathways in the spinal cord and creates inflammation in the cord, and that creates central sensitization, which puts everything off. I'm trying to figure out a way that the 2-week experience you had happened, and I'm thinking about that. But there's a question here who have, Beverly says, more vitamin C to make more connective tissue. And then Maura, do you think your therapy is turning off the malfunctioning gene's ability to express itself? And that appears to be how FSM works, is the protein receptors on the outside of the cell control the kinases, control the genes, the messenger RNA and the microRNA that control the cell's output. We think the frequencies affect cell signaling by affecting the protein receptors configuration, because the effect is very, very frequency specific. So when you have Ehlers-Danlos, every time you stand up with food in your stomach, you basically get a nerve traction injury in the vagus nerve, because the vagus is attached to your gut. So the vagal nerve goes down, inflammation goes up, anxiety and depression go up, digestion gets worse, and it's this vicious cycle. So not eating anything for 2 weeks might have just given your gut a rest, so that the vagus nerve would come back on and your inflammation would go down. Does that make sense?
Oh, yeah, very much.
Jen, what was the aha moment when you found out that, what tests did you do that said, okay, now I'm Ehlers-Danlos and I'm not, just Michiganosis?
Well, I'll tell you, I had, excuse me, I had a big surgery. I had rectocele repair, cystocele repair, and a hysterectomy, all at the same time at 31. And yeah, so obviously not planned. That was my second little pumpkin. We delivered everything. So after surgery took a really long time, and they said something's not right. The tissue just kept stretching and stretching and stretching, like nothing was, it was, the surgeons were blown away in there. So that sent me finally to a geneticist. I had had so many surgeries already before that. Unfortunate, but I was so happy to land in Stanford. So I was in Stanford. It was their Marfan's clinic. They did all the testing, meant the genetic markers, but it felt, I'll tell you, just hearing that diagnosis, it made everything make sense, and it was such a relief.
Yeah.
So
Yeah.
that was the aha moment.
Yeah. How many genes are involved in Ehlers-Danlos? Do they know? It's a constellation, because there's a wide range of symptoms.
There's a wide range of symptoms, and even them at the time, they told me, I've been diagnosed for about a decade now. So they even told me there was still a lot to go. There's more gene markers that are out there that they haven't identified yet. So they said, hey, even if the markers don't come back, you obviously have a connective tissue disease.
Yeah.
So
Well done.
yeah.
Well, if you can find somebody You guys are in Reno. I don't know who we have in Reno, but like literally it doesn't even require manual therapy. You just sit in a chair and your pain goes down, the vagus nerve starts working, the Baton score, like you become not stretchy, which feels weird. And if you have any sort of tethered cord symptoms, you have to treat those separately. So it can be 2 or 3 sessions or 2 or 3 machines in one session, but I don't have to do anything physical until afterwards, when we start reconditioning and strengthening muscles. Once the muscular attachment to the bone is normal tone, it's not stretchy, and get rid of the adhesions in the nerves and the nerve pain, and it's fairly straightforward these days. Like that, I think I did that
Wow.
webinar in 21, that was 2 years ago.
Mhm.
We've had classes now where 30 people in the class, and we had 8 of them with 27 people in the class. We had a big treatment session with 8 patients with Ehlers Danlos being treated after the class. And all
Wow.
8 of them got up pain-free with normal range of motion.
Wow.
All right,
Yeah.
Jen. All right, Jen, we know what our next academic assignment is. We'll be
I like the
we'll be
sound of
putting in
that.
the order tonight.
Yeah, I will let you go. Thank
Okay.
you so much for having
Carol,
me.
thank you so much. There's one more
Thank
question
you.
here. Somebody asked, can high TGF beta 1 not be Marfan's, or is it always Marfan's? So I don't know if that's in your.
I haven't seen that many Marfan's. I haven't seen any Marfan's patients. Everything I've seen so far is Ehlers Danlos, but I don't see why it wouldn't work. If it works in EDS, it should work in Marfan's. They're not going to get shorter. Their limbs are still going to be the same length, but the connective tissue portion of it may resolve. We don't know until we do it. I didn't know we could treat Ehlers Danlos until I did it.
Mhm.
And then I did it twice, and then I did it 10 times. And now we've done it about 50 or 60 times. And so far we haven't had any failures. So we'll find out. Stay
Can I
tuned.
ask
One more question here.
Yeah, just one question. And thanks for your time, Carol. And this was excellent. And I appreciate everything you've done figuring this out. And I'm trying to learn it now. I have a patient, 16-year-old female, who after COVID a couple of years ago, she actually lost her ability to control her control micturition, and she ended up having to start self-cathing herself, and also has an ostomy tube to flush out her rectum and to
Wow.
help her defecate. And I actually suggested to the mother that we consider pulsed electromagnetic frequency only just out of principle. But I was unaware of this strategy. Is this a situation that you've seen before? Is it kind of like the same frequency, 40, 10? And
No,
also,
not actually. There are frequencies. If you think about what happened in the early 1900s, there was an epidemic in 1915, there was an epidemic in 17, and then there was a pandemic in 19. So my frequency list from this osteopath includes 6 frequencies for different kinds of respiratory flu, malignant flu, London flu. There's 6 frequencies for flu. And we created a protocol for this respiratory flu pandemic that we have. And on long COVID, we use those same frequencies in whatever tissue has been affected. So if this patient had COVID, then all of a sudden certain portions of her nervous system stop working, you could try the virus frequencies in those tissues. So there's a patient that came in and that has not been able to smell since she had the virus. And I used the virus frequencies on the ethmoid sinus and on the capillaries in the ethmoid sinus. And at the end of it, so it took about 35, 40 minutes. At the end of it, she could smell coffee. So the sense of smell came back. So it would be worth a try. And then Deborah Dell, frequencies being specific,
Oh,
we
yeah.
are talking resonance. Yes. So it's worth a try. I have no idea if it's going to help.
Yeah, and I forgot to mention, Chief, she does have Ehlers Danlos syndrome. And so I didn't know if, I figured that went along what you said, and it makes so much sense that the vagus nerve is getting stretched and irritated and essentially not functioning as well, leading to hypomotility. And then in her case, she just lost her ability to control those sphincters. But yeah, so maybe a combination of treating. Sorry.
Yeah, it's just whatever part of the nervous system controls micturition and it would be parasympathetic, I would think. And so you treat the
Yes.
parasympathetics and the vagus with the virus frequencies and see if it helps. Can't hurt.
Okay.
And you don't know if
Okay.
it's going to work until you use it. So
Okay, well,
Thank you
Carol,
very much.
There's two more questions. One about,
Yeah.
does it have any connection with Huntington's, and does it do any, your frequency specific treatments for eye, does it help any eye issues? So,
I haven't seen Huntington, so I don't know. And then we have one published paper on, it's actually a control trial on wet and dry or dry and wet macular degeneration. It's more effective in dry macular degeneration. That's in the published papers section of our website. Rheumatoid arthritis pain, yes. Neuropathy, yes. Diabetic neuropathy, yes. Chemotherapy neuropathies, we do well with vincristine, not so well with cisplatin or the platinum chemo agents. Rheumatoid arthritis pain, yes, but it's temporary because you've got to turn the vagus back on to control inflammation, and most of them are on immune suppressants. So, but peripheral neuropathies, radiculopathies, nerve pain, honestly, is the easiest thing we treat. It's kind of crazy, but it's true. And then obviously thalamic pain. That's pretty amazing.
great.
Great group.
Thank you so much, Carol. John, you have anything for us? This is my
well,
right-hand man here.
Yeah, just a
You can
lot
see
of
by the beard.
thanks.
You can see, I hang out with
Yes.
guys with beards here.
There we
Hey,
go.
Carol, just very inspiring again. This is so wonderful to hear about this stuff. And especially since you mentioned Flexner and homeopathy, and because I deal with some of the German stuff, which is homeopathy, neural therapy, and they
Sure.
made their big discoveries in the 30s.
Yep.
So we're going flashback too, but the resistance we've had to homeopathy has been extreme in the last few years.
Sure. Nope, they're after us again. Pharmaceutical companies don't want to be threatened. Bless their hearts. Well, you guys.
I
keep
want-
doing good. Go
I
ahead.
was going to say, I want to pick your brain a little bit. They happen to be building an osteopathic school 30 minutes from my home in West Virginia.
Oh,
And
wow.
they're very open. They're very open-minded. They're real osteopaths. And they're
Right.
walking very, very slowly, very carefully, and keeping their mouth shut about a lot of things. But they also are very aware of the homeopathy and are very advanced practitioners, but they can't talk about it much. So
Yeah.
with the new school that's starting, they hope to do some research, and we hope to work with them, and maybe we could work with you with the research in microcurrent as well.
Yeah. The nice thing about FSM is because what I teach is protected by the First Amendment. I'm a clinician sharing my clinical research with other clinicians, and the devices are completely separate company. I'm not a part of that.
Right.
So the devices are regulated as if they are TENS devices. And we just stay away from the devices. I just talk about the effect of the frequencies. So that's the way we do it. And I talk about FSM sometimes as electronic homeopathy. So it's just simpler because it's very specific. You know, if you look at a homeopathic remedy, there's a whole page of indications, right? And then it's doing a homeopathic, what do you call it, prescription, figuring out what to give somebody. It may take weeks or a month to know. With FSM, you know, in 10 to 30 minutes if it's going to work and how well it's going to work. So congratulations on the osteopathic college.
Oh, that's everything you're saying is fantastic. Thank you very much.
You're
Thanks,
so
Carol.
welcome.
Thanks
for having
again.
me.
Thank you so much. I know you're traveling again, right?
Yep. Tomorrow we're headed for Orlando.
Okay,
So
great.
you guys have a good time. Thanks for having me.
Okay, thank you, and we will certainly want you back again.
Okay.
Video will be up as soon as I can get it up, and the slideshow also. I have here in her in the chat. I have the specific frequencyspecific.com. Is that right?
Yep. Frequencyspecific.com.
Okay, and then the AOSRD. That's where all our videos and slide notes are.
Okay.
Dr.
Sounds
Stein
good.
put up, I don't know what article that is. It's from some journal. I'm not sure what it is, but there's a link to an article there. Next week, Dr. Halasa is going to be talking about his latest discovery. So he's got something interesting to share with us. I will probably not be here. I am going to visit grandbabies on Friday morning, and I will be through next Tuesday. So Joel's going to be taking over. Don't be kind to him. Don't throw too many tomatoes. I'll be in Michigan. I'll try to get on, but I don't know if I'll be able to or not. And also just a look ahead, July 4th is a Tuesday and I'm taking it off. So we're going to be off that week. So you'll just have to, bear with us for 1 week. Can
I steal from you, Dr. Carol, because her presentation was awesome and phenomenal, and there's lots of things that we can add to what she's presenting.
Yeah. Okay. Okay. So any questions, comments, complaints? John, got anything else?
All's good.
Okay, all's good. Joe, got anything? Anybody else? I see Dr. Benoit was on this week. We're gonna see if we can get him back. Anybody else? Anybody who has anything that they'd like to present, please let me know. We're always open. Next week again, Dr. Halasa will be speaking for us. Dr. Cruz, nice to see you again. And everybody else, there were a couple of new names, and Dr. Stone, a couple of new names, Dr. Smith, and some old friends too. So we'll be out same time, same station, and we'll be seeing you next week. So good night, everybody. Have a great week.
Thank you.